Thank you for answering the pre-test. I am Dr. Maria Teresa de Castro, a PPS STC member and a behavioral and developmental pediatrician. Welcome to Anak, Please Anak, Attention to Inattention, an online CPD on ADHD. Some people believe it is a modern-day excuse for misbehaviors in children, but historically, this has already been observed and described as early as 1902. After the great influenza encephalitis epidemic in 1917, a conglomeration of symptoms of restlessness, inattention, impulsivity, and hyperactivity was widely documented, which proved that indeed, ADHD really exists and continues to be a neurobiological disorder with a multifactorial etiology. At the end of this session, we are expected to achieve the following objectives. ADHD is one of the most common behavioral disorders in school-age children. Manifestations usually are first observed in the home and classroom settings. Given this time and age, many people still lack the proper information about this condition, thus giving rise to many perceptions, which in most cases are inaccurate. Unnecessary tags are unfortunately given to kids suffering from this disorder. The Diagnostic and Statistical Manual of Mental Disorders 5th edition is currently the diagnostic criteria we use in ADHD, and despite the revisions made, the behaviors that we commonly know remain the same with inattention, hyperactivity, and impulsivity being in the core symptoms for ADHD. For the hyperactivity, mother would commonly describe an ADHD child as an energizer bunny, while the teachers would oftentimes perceive him like a supervisor roaming inside the classroom. Impulsivity manifestations in the home would manifest like butting or interrupting others' conversation, while the teacher would notice the over-eagerness of her student to blurt out answers inside the classroom. Mom would oftentimes notice his inattention when she buys pencils all the time or whenever the child loses things necessary in school. On the other hand, teachers would see inattention in the form of carelessness with his seat works, and he underachieves with what he can actually get because of his countless unmindfulness. As frontliners in childcare, pediatricians are often asked by parents on what is true about ADHD. What do we then tell our parents? Are we giving them the right information? Do we attempt to educate them too? There is a growing number of myths about ADHD, and it is about time to demystify and learn the facts. Myth number 1. You can't have ADHD. You are not hyper. Fact is, in ADHD you have 3 types: the predominantly inattentive, predominantly hyperactive, and the combined type, with the latter accounting for most of the ADHD cases. In fact, school-age children and adolescent girls are more likely to comprise the predominantly inattentive subtype. Therefore, diagnosing ADHD should not be limited to the hyperactive symptoms alone. Even in this local study done in 2002, inattention symptoms such as lacking in focus and easy distractibility are the more prevalent presentations of ADHD rather than the hyperactive symptom characterized as being always on the go. Myth number 2. He is just being a kid. He will outgrow it. Overwhelming studies have shown that ADHD is not a childhood disorder alone. Its prevalence in children is about 7.5%, but this persists in 40 to 70% in adolescents and even reaching 50% in adulthood. Myth number 3. ADHD kids on medication will become drug dependent. In a study in 2003, the intake of medication reduces significantly the risk-taking behavior associated with ADHD. We also have to consider other comorbid conditions like conduct disorders or other psychiatric disorders, which may predispose a person with ADHD to become drug dependent. The safety and efficacy profile of ADHD medication when prescribed under the direction of competent doctors have been proven for more than 50 years, and that they can prevent addiction and not promote it. Myth number 4. Kids with ADHD are just poorly disciplined. It is just the result of bad parenting. Fact is, ADHD is considered as a neurodevelopmental disorder. Although poor parenting can somehow contribute to the severity of the symptoms associated with ADHD, it is not the real cause of this condition. Parents need not to be blamed for the emergence of the symptoms of ADHD. If a child misbehaves, it is not because he was not taught, but he just couldn't control his impulses, which is highly characteristic to this condition. This is a very common myth. He has ADHD because he has too much sugar in his diet. Despite this common belief, there is no supportive evidence that sugars actually cause ADHD. An overwhelming number of studies have not been able to demonstrate behavior changes due to sugar consumption. However, you may advise parents to limit sugar consumption for calorie reduction or prevention of dental caries, but not to prevent ADHD. To further debunk these myths, ADHD in fact is a real neurobiological disorder. Subcortical brain volume difference in participants with ADHD in children and adults was found in a cross-sectional mega-analysis which was published in 2017. With funding from the National Institutes of Health, researchers from the Enigma ADHD Working Group embarked on what they said is the largest study performed on brain differences in people with or without ADHD. They found smaller brain volumes in different regions of the brain of ADHD people, and they dubbed ADHD as a disorder of brain maturation delay, with structural differences greatest in children, but no significant difference in adults with ADHD compared with control group. Various studies also support the neurotransmitter deficit theory, further supporting this neurobiological mechanism in ADHD. The neurotransmitters are often called chemical messengers. They are essential in the communication system between the brain and the rest of the body. One important neurotransmitter is dopamine. It affects movement, mood, motivation, and attention. Another equally important neurotransmitter is norepinephrine. It influences brain function and is more responsible in keeping us alert. Norepinephrine also has an important role in planning, understanding sequence and time, and our ability to focus on what is more important. Recent studies show that individuals with ADHD have an excessively efficient dopamine removal system, wherein there are higher levels of dopamine transporters which are responsible for the reuptake in the presynaptic neuron. When dopamine is removed too quickly, it doesn't have sufficient time to exert its effect on the postsynaptic neuron to proceed with the messages expected to be delivered in the different regions of the brain. This might be the same mechanism seen in norepinephrine. Neurotransmitter deficits are said to be influenced by gene expression, and these deficits cause the different subtypes. A PET scan shows the amount of activity in different areas of the brain. The PET scans from several studies made by the National Institutes of Mental Health show that the brain with ADHD generally has much less activity than a brain without ADHD, as depicted by the red, orange, white colors in the different regions of the unaffected brain. This lack of activity of the brain of a child with ADHD signifies diminished cerebral blood flow, particularly in the areas of the frontal lobes and striatal portions of the caudate nucleus. In this situation, a great paradox exists that while the child with ADHD may seem hyperactive on the outside, his brain is dormant and lacks the activity and proper neural stimulation and connection on the inside. Do you know these famous personalities and icons? I'm sure you do. A very famous actor, a renowned person in the area of technology, one of the greatest painters of all time, and a well-celebrated and decorated swimming Olympian. They all have ADHD, and they are a living testimony that ADHD people do amount to something and even greater. In 2013, the 5th edition of the Diagnostic and Statistical Manual of Mental Disorder was released, and the revisions done were as follows. The age of onset was adjusted before the age of 12 instead of 7 years old. Another revision made is that impairment was replaced with symptoms that should be present in more than one setting. Lastly, the cutoff remained to be 6 symptoms except for kids 17 years old or older. ADHD may already be considered if the symptoms are at least 5 in this age group. Let us now familiarize ourselves with the inattention symptoms in ADHD. The child fails to give close attention to details or makes careless mistakes in his work. He has difficulty sustaining attention. When spoken to directly, he oftentimes seems not to listen. He does not follow instructions or he fails to finish his work on time. Often has difficulty organizing tasks and activities. He often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. Often loses things necessary for tasks like pens or pencils. He is easily distracted. And lastly, often forgetful in daily activities. There is a total of 9 symptoms included in the inattention criteria for ADHD. The following are the last 9 symptoms included in the hyperactivity and impulsivity symptoms in ADHD. He is often seen restless or fidgety, especially when seated. Often leaves his seat in situations when remaining seated is expected. Often inappropriately runs or climbs in certain situations. He is unable to play quietly. Is often on the go as if driven by a motor. Often talkative. Impulsive symptoms are characterized by blurting out the answers even before a question has been completed. Has difficulty waiting for his turn. And the last impulsive criterion is the interruption on others' conversations and/or activities. To help us better remember the DSM V criteria for ADHD, consider these following figures. The rule of 6. That 6 or more of the following symptoms of inattention or hyperactivity or both have persisted for at least 6 months to a degree that is inconsistent with the developmental level. ADHD begins in childhood and symptoms should be present before 12 years of age. Several inattentive or hyperactive impulsive symptoms should be present in 2 or more settings like the home and the school. There should also be a clear evidence that the symptoms interfere with or reduce the quality of academic, social, or occupational functioning. The symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and not better explained by another mental disorder. For the management and treatment, the primary care physician should establish a program that will recognize ADHD as a chronic condition, educating not only the child with ADHD but his primary caregivers about ADHD as a brain-based problem is the first step to ensure continuity of care and good outcome. In the next few slides, I will be discussing the AAP clinical practice guidelines on the treatment of school-aged child with ADHD. The management of ADHD is tailor-fit to the needs of a child. Impairments may differ greatly from child to child. Therefore, specifying target outcomes should be prioritized. These target outcomes should reflect the key symptoms that a particular child with ADHD manifests. Here are just some of the examples of target outcomes. Academic productivity, following classroom rules, homework, behavior outside the classroom. After identifying target outcomes, we can now proceed to more specific intervention like giving of medication with or without behavioral therapy. The multimodal treatment of ADHD, or what is commonly known as the MTA study, is funded by the National Institutes of Mental Health. The study concluded that medical treatment alone is stronger and that its combination with behavior therapy is comparable in the treatment of the core symptoms in ADHD. However, for those with more non-ADHD domains like oppositional defiant disorder or internalizing symptoms like anxiety and depression, the combination therapy is more superior to medication alone and is better in cases of poor parent-child relationships. Based on the ratings provided by the parents and teachers on the primary ADHD symptoms, the combination of behavioral and medical management yielded a higher approval outcome with the least in the behavior management alone. Some factors were associated with worse outcomes, and these are severity of initial symptoms, male gender, presence of oppositional or disruptive behavior, those needing more public assistance, and the presence of ADHD in a parent. For the medical management, stimulants are most widely prescribed and supported by far with more than 200 scientific studies. In terms of efficacy and safety, it is considered as a drug of choice. Its mechanism of action is mainly to increase the dopamine and norepinephrine levels, specifically in the caudate nucleus and prefrontal cortex. The stimulants available in the Philippines are as follows. With the once-a-day dosing of the extended-release formulations, higher adherence to the medication was observed. The convenience of taking it after breakfast further reduces the embarrassment associated with the stigma of taking medication for ADHD kids, especially in the school-age children. The dictum that we follow in medical management is to give the dose that works best and achieves the target symptoms without significant side effects. About 70% responded when used systematically. Stimulants work best in reducing the core symptoms of ADHD, but may also target noncompliance and impulsive aggression. The behavioral effects may already be seen as early as 30 to 45 minutes after intake, and attention somehow increases after 1.5 hours. In adolescents taking stimulants, it reduces the risk for addiction and/or alcohol use. Some of the reported side effects are as follows, with headache being one of the most common. Stimulants are contraindicated when hypersensitivity to the drug or its components occur, or those with glaucoma, or those taking monoamine oxidase inhibitors. Those who are actively psychotic and with an ongoing drug abuse may not anymore benefit from a stimulant treatment option. The non-stimulants are the second line of treatment in ADHD. It may remain as an option for children and adolescents for whom non-stimulants are not effective. Non-stimulants are also best suited for those who experience significant side effects to stimulants or in the presence of exacerbation of other coexisting disorders. The non-stimulants, as exemplified by atomoxetine, is a norepinephrine reuptake inhibitor. Compared with stimulants, wherein both the dopamine and norepinephrine levels are increased, non-stimulants have their effects in the levels of norepinephrine alone. However, lesser side effects in sleep is the added benefit of non-stimulants are found to be more effective in those with tics and accompanying aggression. Effective psychosocial treatment for ADHD employs the principle of behavior training, which include behavior modification techniques and social learning theory. The emphasis is on contingency plan when something comes up, and this shapes the child's behavior by observing, modeling appropriate behaviors, modifying attitudes, and understanding the emotional reactions of other people. The behavioral techniques can be individual or group training, which may target compliance with directions, time management, and establishment of good study skills. The psychosocial treatments utilize adults to implement change in children with ADHD and mainly focus on parent training and school-based interventions. While for adolescents and adults, supportive psychotherapy is mostly offered, which show improvement in their self-esteem, treatment of comorbidity, lessening stress, and have beneficial effect in their functionality. It is, however, emphasized that behavioral interventions alone are often insufficient for treating the core symptoms of ADHD. Hence, it is best to combine them with medications. For parents who are really hesitant to start their children on medication, behavior treatment should require close monitoring of symptoms and close supervision and re-evaluation of progress or deterioration. For specific school interventions, provision of classroom accommodations to improve learning may be given for mild cases. Such accommodations are exemplified by preferential seating, like sitting in front near the teacher, but the child must not be seated near a window or a door. Assignments may also be reduced, and the assigned therapists may assist the classroom teacher in formulating classroom behavior programs depending on the child's needs. An ADHD coach may also be hired who may train the child in the executive skills development and in helping the child become an efficient student. For more severe cases, like those with an accompanying learning disability or with more challenging comorbid behavioral conditions, it is ideal to get a comprehensive educational testing and to design an individualized education program or IEP to cater for the specific academic and behavioral needs of the child. To monitor this, a daily home school report card is suggested. In this way, the daily behavioral pattern may be evaluated and managed accordingly. Here are just some tips for teachers of children with ADHD. Write directions on the board. Break instructions into small steps. Have the child sit in the front of the class. Give more time for tests and writing assignments. Remind the child to turn in homework. Provide a structured learning environment. Let the child use tape recorders to record lessons. Use simplified textbooks. Tailor homework assignments. Other tips may include reward positive behavior. Ignore negative behavior as much as possible. Do not give bad marks for the child's work because of difficulties caused by the attention disorder, and do not punish the child because of difficulties arising from lack of organization or problems with attention. Some people might think that giving these considerations and special accommodation strategies for students with ADHD is unfair. Fair is not everybody getting the same thing. Fair is everybody getting what they need in order to be successful. Students with ADHD often benefit from these special ADHD accommodations, and this help make the level of playing field equal for all students. Some homework tips are the following. We have to establish a routine and schedule for homework, like giving specific time and place for study. We have to limit distractions in the home during homework hours. Praise and compliment your child when he puts forth good effort and completes tasks. In a supportive, non-critical manner, point out some corrections and errors on the homework. It is not your responsibility to correct all your child's errors on homework or make him complete and turn a perfect paper. Remind your child to do homework and offer incentives. If your child struggles with reading, help by reading the material together or reading it to your child. Work a certain amount of time and then stop working on homework. This figure illustrates the developmental trajectory of kids with ADHD. If the child with ADHD is unmanaged, several complications may arise, mostly as a consequence of his underachievement in his academic work, which may subsequently lead to issues in self-esteem, lack of motivation to pursue his studies, and may possibly result to more challenging behaviors like oppositional, mood, or conduct disorders. Compared with his peers without ADHD, a child affected with this disorder is 5 times at greater risk for substance abuse, antisocial behavior, and other psychiatric disorders. To learn more about ADHD, I have selected some important websites which you can use as a reference. I'm also leaving you some useful educational resources which you can read and share with the family members and teachers of your ADHD patients. Thank you for your utmost focus and attention. Please answer the post test. All for the Filipino child.